Selamat datang di Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita. Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita terdiri dari gedung utama, gedung ventrikel, gedung penelitian dan pengembangan, gedung perawatan 2, gedung utility dan gedung pendidikan dan pelatihan. Saat ini kita berada di gedung ventrikel lantai 5. Pada lantai ini terdapat ruang rapat Nusa Tenggara, ruang rapat Kalimantan, dan ruang rapat Sumatera. Saat ini kita berada di ruang rapat Kalimantan dan atau di ruang rapat Sumatera. Ruang rapat ini dilengkapi dengan berbagai fasilitas tanggap darurat, meliputi 2 pintu keluar dan 2 tabung alat pemadam api ringan yang masing-masing berada di depan ruang rapat dan di sisi kanan arah keluar. Terdapat 2 tangga darurat yang berada di sisi kiri dan kanan luar ruangan rapat. Pengunjung tidak diperkenankan merokok selama di area Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita, termasuk di area ruang rapat ventrikel lantai 5. Hari ini tidak ada kegiatan pengujian sistem pengujian tanda bahaya. Apabila Anda mendengar alarm tanda bahaya, maka hal itu merupakan tanda peringatan kondisi darurat. Tetap tenang dan ikuti instruksi yang diberikan melalui pengeras suara atau layar monitor di ruangan Anda. Bila terjadi gempa, segera lindungi kepala Anda menggunakan barang seperti tas atau buku. Segera berlindung di bawah meja atau berjalan ke arah koridor. Hindari dinding kaca, lemari, atau rak yang perabotnya mudah jatuh atau mudah bergeser. Jika terjadi keadaan darurat atau kebakaran, harap tenang, jangan panik. Hentikan aktivitas segera. Matikan sumber listrik yang sedang menyala. Bila terjadi kebakaran, teriakan kode merah sebanyak 3 kali dan lakukan pemadaman api dengan apar terdekat sampai petugas datang ke lokasi. Segera hubungi 1104 untuk keadaan darurat. Dan untuk kegawat daruratan medis, hubungi 1000. Apabila terjadi kondisi darurat, maka Bapak Ibu yang ada di ruangan ini mohon dengan tenang menuju ke jalur evakuasi yang dipandu dengan mendengarkan arahan petunjuk dari petugas Unit Penanggulangan Bencana dan Kebakaran atau UPK atau security atau dari pengeras suara. Jangan panik, segera berjalan dengan cepat dan tertib meninggalkan ruangan ini, mengikuti jalur evakuasi dan hindari pemakaian lift. Segera keluar melalui tangga darurat menuju titik berkumpul atau master point yang telah ditentukan, yaitu di lapangan parkir depan Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita. Bagi Anda yang menggunakan kursi roda, kruk atau wanita hamil akan didampingi oleh petugas evakuasi menuju titik berkumpul atau master point. Setelah tiba di titik berkumpul, dilarang memasuki gedung kembali. Petugas evakuasi kami akan memastikan bahwa tidak ada orang yang tertinggal dalam ruangan. Demikian safety briefing yang berlaku di ruang rapat gedung ventrikel lantai 5, Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita. Terima kasih atas perhatian Bapak Ibu dan selamat beraktivitas. Selamat datang di Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita. Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita terdiri dari gedung utama, gedung ventrikel, gedung penelitian dan pengembangan, gedung perawatan 2, gedung utility dan gedung pendidikan dan pelatihan. Saat ini kita berada di gedung ventrikel lantai 5. Pada lantai ini terdapat ruang rapat Nusa Tenggara, ruang rapat Kalimantan, dan ruang rapat Sumatera. Saat ini kita berada di ruang rapat Kalimantan dan atau di ruang rapat Sumatera. Ruang rapat ini dilengkapi dengan berbagai fasilitas tanggap darurat, meliputi 2 pintu keluar dan 2 tabung alat pemadam api ringan yang masing-masing berada di depan ruang rapat dan di sisi kanan arah keluar. Terdapat 2 tangga darurat yang berada di sisi kiri dan kanan luar ruangan rapat. Pengunjung tidak diperkenankan merokok selama di area Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita, termasuk di area ruang rapat ventrikel lantai 5. Hari ini tidak ada kegiatan pengujian sistem pengujian tanda bahaya. Apabila Anda mendengar alarm tanda bahaya, maka hal itu merupakan tanda peringatan kondisi darurat. Tetap tenang dan ikuti instruksi yang diberikan melalui pengeras suara atau layar monitor di ruangan Anda. Bila terjadi gempa, segera lindungi kepala Anda menggunakan barang seperti tas atau buku. Segera berlindung di bawah meja atau berjalan ke arah koridor. Hindari dinding kaca, lemari, atau rak yang perabotnya mudah jatuh atau mudah bergeser. Jika terjadi keadaan darurat atau kebakaran, harap tenang, jangan panik. Hentikan aktivitas segera. Matikan sumber listrik yang sedang menyala. Bila terjadi kebakaran, teriakan kode merah sebanyak 3 kali dan lakukan pemadaman api dengan apar terdekat sampai petugas datang ke lokasi. Segera hubungi 1104 untuk keadaan darurat. Dan untuk kegawat daruratan medis, hubungi 1000. Apabila terjadi kondisi darurat, maka Bapak Ibu yang ada di ruangan ini mohon dengan tenang menuju ke jalur evakuasi yang dipandu dengan mendengarkan arahan petunjuk dari petugas Unit Penanggulangan Bencana dan Kebakaran atau UPK atau security atau dari pengeras suara. Jangan panik, segera berjalan dengan cepat dan tertib meninggalkan ruangan ini, mengikuti jalur evakuasi dan hindari pemakaian lift. Segera keluar melalui tangga darurat menuju titik berkumpul atau master point yang telah ditentukan, yaitu di lapangan parkir depan Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita. Bagi Anda yang menggunakan kursi roda, kruk atau wanita hamil akan didampingi oleh petugas evakuasi menuju titik berkumpul atau master point. Setelah tiba di titik berkumpul, dilarang memasuki gedung kembali. Petugas evakuasi kami akan memastikan bahwa tidak ada orang yang tertinggal dalam ruangan. Demikian safety briefing yang berlaku di ruang rapat gedung ventrikel lantai 5, Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita. Terima kasih atas perhatian Bapak Ibu dan selamat beraktivitas. Selamat datang di Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita. Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita terdiri dari gedung utama, gedung ventrikel, gedung penelitian dan pengembangan, gedung perawatan 2, gedung utility dan gedung pendidikan dan pelatihan. Saat ini kita berada di gedung ventrikel lantai 5. Pada lantai ini terdapat ruang rapat Nusa Tenggara, ruang rapat Kalimantan, dan ruang rapat Sumatera. Saat ini kita berada di ruang rapat Kalimantan dan atau di ruang rapat Sumatera. Ruang rapat ini dilengkapi dengan berbagai fasilitas tanggap darurat, meliputi 2 pintu keluar dan 2 tabung alat pemadam api ringan yang masing-masing berada di depan ruang rapat dan di sisi kanan arah keluar. Terdapat 2 tangga darurat yang berada di sisi kiri dan kanan luar ruangan rapat. Pengunjung tidak diperkenankan merokok selama di area Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita, termasuk di area ruang rapat ventrikel lantai 5. Hari ini tidak ada kegiatan pengujian sistem pengujian tanda bahaya. Apabila Anda mendengar alarm tanda bahaya, maka hal itu merupakan tanda peringatan kondisi darurat. Tetap tenang dan ikuti instruksi yang diberikan melalui pengeras suara atau layar monitor di ruangan Anda. Bila terjadi gempa, segera lindungi kepala Anda menggunakan barang seperti tas atau buku. Segera berlindung di bawah meja atau berjalan ke arah koridor. Hindari dinding kaca, lemari, atau rak yang perabotnya mudah jatuh atau mudah bergeser. Jika terjadi keadaan darurat atau kebakaran, harap tenang, jangan panik. Hentikan aktivitas segera. Matikan sumber listrik yang sedang menyala. Bila terjadi kebakaran, teriakan kode merah sebanyak 3 kali dan lakukan pemadaman api dengan apar terdekat sampai petugas datang ke lokasi. Segera hubungi 1104 untuk keadaan darurat. Dan untuk kegawat daruratan medis, hubungi 1000. Apabila terjadi kondisi darurat, maka Bapak Ibu yang ada di ruangan ini mohon dengan tenang menuju ke jalur evakuasi yang dipandu dengan mendengarkan arahan petunjuk dari petugas Unit Penanggulangan Bencana dan Kebakaran atau UPK atau security atau dari pengeras suara. Jangan panik, segera berjalan dengan cepat dan tertib meninggalkan ruangan ini, mengikuti jalur evakuasi dan hindari pemakaian lift. Segera keluar melalui tangga darurat menuju titik berkumpul atau master point yang telah ditentukan, yaitu di lapangan parkir depan Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita. Bagi Anda yang menggunakan kursi roda, kruk atau wanita hamil akan didampingi oleh petugas evakuasi menuju titik berkumpul atau master point. Setelah tiba di titik berkumpul, dilarang memasuki gedung kembali. Petugas evakuasi kami akan memastikan bahwa tidak ada orang yang tertinggal dalam ruangan. Demikian safety briefing yang berlaku di ruang rapat gedung ventricle lantai 5, Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita. Terima kasih atas perhatian Bapak Ibu dan selamat beraktivitas.
Honorable Speaker from Philips Asia Pacific Region, Mr. Kevin Kim, and all the Philips team. Assalamualaikum warahmatullahi wabarakatuh. Shalom. Welcome to the Healthcare Technology Seminar for Harapan Kita. My name is Mariana and I'm the host for today. I would like to also to greet the Honorable Head of Health System Solution, Philips Asia Pacific Region, Mr. Kevin Kim. The President Director of National Cardiovascular Center Harapan Kita, Dr. Iwan Dakota, and all Board of Directors, all management who are in this room, and everyone who are attending via Zoom or YouTube. Today, we will have a very interesting seminar in digital transformation, based smart hospital and future healthcare technology. For the next 1.5 or 2 hours, we will learn many things. Allow me to read for you the agenda for today. First, there will be welcome remarks and brief presentation from Dr. Iwan Dakota. And then we will have a 3 sessions seminar, which are divided into digital transformation, based smart hospital, co-creating smart hospital and reference case. And then the third one, future healthcare technology and digital twin. And each session, there will be a question and answer. So all who gather here or via Zoom or YouTube can ask the questions. Okay, without further ado, I would like to invite on the Honorable President Director of National Cardiovascular Center Harapan Kita, Dr. Iwan Dakota, to give a welcome speech and a brief presentation. Please welcome.
Baik, apakah suara saya terdengar ya? Mohon informasi Bapak Ibu sekalian. Baik.
Dengar jelas, Dok.
Baik, Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera bagi kita semua. Sorry, Mr. Kevin, I'm speaking bahasa for a while. Oke, atas nama manajemen Rumah Sakit Jantung Harapan Kita, kami mengucapkan terima kasih atas kehadiran Bapak Ibu sekalian. Baik hadir secara luring di sini maupun secara daring. Saya lihat ada beberapa dari teman-teman dari rumah sakit jejaring di Indonesia yang hadir secara daring. Baik, Bapak Ibu sekalian, hari ini senang sekali kita bisa berkumpul bersama dalam rangka acara yang sangat menarik sekali, yaitu Future Hospital, kemudian yang terkait dengan Smart Hospital. Mungkin saya akan bisa slide sedikit barangkali, ya. Kita share slide, oke. Well, I think I should speak in English. So, slide please. So the problems now is we're talking about what is the future hospitals looks like. We're looking at the industrial revolution of there are 4 stages: first stage, second stage, third stage. Now we know on the 4th industrial revolutions, which is what we call emphasize on digitalizations. So we know the Internet of Things, cloud, digital coordination, cyber, physical system, and robotics. This is very important for us, including in hospital care. Slide. What kind of technology and the future healthcare will be? If you're looking at the AI application in healthcare, there are so many things, including the diagnostic improvement, drug development, medical diagnosis, including the doses, as well as the research and personal healthcare. Nowadays, we have the virtual nursing assistants and cybersecurity, gene editing, AI, and healthcare monitor. Slide, please. Yes, this is what actually happened right now. One in the hospitals in the Brazils, they have the common room like this. This is, you can call it a war room. So the management system, they have the executive dashboard to see everything in the hospitals. Slide. So the future hospital as well that we emphasize on digitalizations. The AI has already implemented in the daily activities in the operating theaters, in the as well as in the other rooms. So this is what actually happened soon in the healthcare, especially in the hospitals, right? Another important thing is regarding the technology of the healthcare, the trends right now and what kind of innovation will be. The most important thing that we know that availability of information and big data. We also improve the communication, integrated medical records. I think all of the hospital right now, most of the hospital right now has already implemented the electronic medical record. Then we are noted that the artificial intelligence will be available soon in the healthcare, especially in the hospitals. The automated process has already developed. It's depend on each hospital. I think in Harapan Kita, we apply most of the processes will be on automated processes. Slide. And then another important thing for the healthcare doctors or specialists, they use more sophisticated gadgets such as like a smaller, more simple, and more mobility, as well as the high quality image. They can just only use the gadget like a handphone or whatever with the probes, small probes, which is replacing the ordinary probes. It has already applied in some hospitals. Actually, it will be available soon in our hospital as well. Slide. So what is the potential benefit of the 4th industrial generations in the hospitals. Slide. Okay. The most important things, there is integration of technology in healthcare, either telemedicines, electronic health or medical record, artificial intelligence, the robotics. I think that we are going to the robotic system for the surgery, and genomics, of course. And our Ministry of Health has already commented the big data analytics for the nationwide. Slide. And another benefit, technology which will be provided in the healthcare and medical fields, including the precision and efficiency of medical treatment, increased communication skills to our employee, of course, our doctors, nurse, and administration officers. They should increase their communication skills, and they should know and exposed to the digitalizations in our hospitals. It will be reveals and bring us to the better quality of care and a faster disease diagnostic as well as for the treatment. And then we are going to the more personalized care or precision medicines. Slide. So what is the challenge actually? Slide. The challenge now, number one is regarding to fast change of technology. Number two is organization strategy should be changes, and then we are dealing with the data security and personal's data security, as well as for competency availability. We need to train our employee in terms of the competency of implementing our technology, especially digital technology, as well as for the artificial intelligence. Slide. Yes. Another. How about the impact in our hospitals? Slide. Yes. Last but not least, number one is change in job roles. I think the human resource director should be emphasized on how to change the job roles, because more automatic process will be available in our hospitals. Slide. Yes, and then we need a skill required for the future roles. Skills, especially on the digitalization, is very important, not only for our doctors and nurses, but all of the employees who works in the hospitals. Slide. So that's why we have to make a decisions to make a strategy preparing for adopting technology. Of course, the human resource director will emphasize on continuing training and upskilling. They should be based on the building digital literacy to the all employees in our hospitals, fostering adaptability and the change management skills. This is very important, especially for the director of human resource. Slide. I think this is last but not least. This is the take home message. The fourth industrial revolution has a positive impact on field of medical service efficiency, quality of care, and the efficiency. Number two, as the technological developments, especially in digitalization in the field of healthcare, it has a challenge, including our personal data security and adaptation of the human resource workforces. And if you're looking at the impact of the fourth industrial revolutions or digitalizations of human resource, including we should note that there is change in the job roles or the descriptions. The more you apply the digitalization in our hospital, I think that we should change the job roles for our staff, need for new required skill and optimization in the workflow. Last but not least, I would like to have great appreciation to the organizing committee as well as the Philips as our vendors, especially to Mr. Kim, Mr. Kevin Kim, who has already around. I think he's around right now. And thank you very much for your cooperation. I hope that we will have a good collaboration with the Philips and others colleagues who attend this meeting virtually, and then some of them are have a meeting in Kalimantan Road. Thank you very much.
Thank you very much, Dr. Iwan Dakota. Please have applause, everyone, for the speech. Thank you so much. And carry on for the next session. Before we continue to the next session, allow me to read you the bio of Mr. Kevin Kim. Okay. Mr. Kevin Kim graduated from Sogang University, Seoul, Korea, from Bachelor of Law, continued to the Georgetown University to take MBA or Master of Business Administration, and then completed his doctoral program in digital health in Sungkyunyang University, Seoul, Korea. And right now he is the head of Health System Solutions, Philips Asia Pacific region. And then we will have today next a digital transformation to base smart hospital. Please welcome Mr. Kevin Kim. We will have 30 minutes presentation and then continuing 15 minutes to question and ask. Okay.
Thank you for your time and having us today. I really appreciate on behalf of Philips, think this opportunity as a very meaningful opportunity to share the global practice of digital healthcare and the smart hospital aspect. Especially before I jump into my presentation, just wanted to share my feedback that earlier, Mr. President of Harapan Kita Hospital, Doctor presented some of the global challenges and also the digitalization and other vision and strategy of Harapan Kita. And I think it's really well resonates to Philips, and also it's a very well planned in terms of a phased manner, because digitalization is really, really complicated and very tough to address at the one time. So thank you for sharing all the background information, which is really the true, what's happening, not just in Indonesia, but also in Asia Pacific and also global healthcare industry. So I won't be sharing lots of background and purpose of digital transformation or the needs of a smart hospital. I will be more focusing today's session on the technology utilizing the reference cases. So today's session, the 3 session I prepared, it's not about product presentation today. It's more on the digitalize and concept, how it's implemented, how it brings you the value and outcome oriented. So let's get started. The first topic that I prepared is a digital transformation-based smart hospital. And before I jump into that, if I may, I prepared 2 slides for the Philips introduction. I know you know Philips brand well, but in terms of a new technology, Philips has been investing millions of euros during past more than 20 years in terms of big data, AI, wearable, telemedicine, etc. And as you see, Philips brand ranks global number 6 in terms of AI patent company. And we were also recognized as one of the most innovative company in the healthcare industry. And also Philips, the uniqueness of the Philips brand is, as you see, we have a lots of product and solution portfolio, not just addressing specific department, but it overcomes the healthy living or prevention, diagnosis, treatment, and home care. Of course, today's presentation, some of the solution or product is not registered in Indonesia. It's still used in the US or Europe. So most of the reference case will come from that region. And also we address emergency room, ICU, general ward, radiology, cardiology, and even pathology, etc. So it's very hard to find one global brand addressing multi-department at the hospital. We've done lots of smart hospital consulting and also services to the global hospitals. And we also look forward to support the Harapan Kita as well. But from our experience, we realized there were the guiding principle for the smart hospital. The 3 value comes in is a clinical excellence, Second is operational efficiency. The last one is experience centricity. And the last one maybe is not familiar to you. So experience centricity is more on the patient and family, and also all the clinicians and the workflow force working at the hospital level. They should all have very efficient, comfortable, safe environment and experience when visiting or working at your hospital. And also the smart hospital, as you may imagine, in very brief way, it's a first, you have to collect all the data. When I say data, it's not only the patient data, but also how the hospital is operationalized. For instance, if you use EMR, you do administrative work. When you do that, there's a time mark when this patient arrived and admitted, and also the admission at the test labs or radiology department for the scan ready. And there's another click that you do in your EMR. And all these clicks that you work on, non-medical, non-patient related, but more administrative, the workflow, that is also the big data. And then the big data can be used for AI to make it more efficient and also monitor and also provide the better workflow that you can design for your own hospital. So at the end of the day, how we believe is the smart hospital is more the data. That's the first phase we recommend the customer, the hospitals and clinicians to look into. And this message was also embedded in the earlier presentation from the Mr. President who shared. It was one of the phase that he was also focusing. And that's what we also focus. Because if you see, digitalization starts from data acquisition and integration. And then with that data, AI can support you. And also AI can then eventually requires the validation in terms of a clinical validation or operational validation. So if we miss the data of the first phase and the second phase, AI will be wrong. And everything else in the following steps will be wrong. Everything will be messed up. The reason I focus on this is then what is the important area in terms of data, right? It has to be standardized. The data should be normalized and it should be following the global standard of the data. For instance, for imaging data, it PACS image like MR or the angio X-ray, all the PACS data, there's a global standard. DICOM is the global standard, which almost every country, including Indonesia, follows. If you're not aware, DICOM is already followed. So that's really good. But what if the numeric data? What's the waveform data? What are the standards? We have to follow or acquisite the high quality data and the standardized and normalized. But unfortunately, lots of health tech companies overlook this. They always tell you, oh, we can collect data. We can collect data, can, but is it standardized? You always have to ask the vendor, is it normalized? Is it quality control there? You have to test your vendor, including us, please. And I cannot stress more on the data collection because if this screws up again, it's gonna be garbage in and garbage out. Maybe you heard this terminology. When I say the garbage in is a data garbage, and with that garbage data, you generate garbage AI. I'm very cautious. I'd like to use another example, but I'm not gonna mention the brand because it's recorded. It's not Philips. It's one of a global brand who launched the precision medicine platform in the US. And they said they prepared the treatment recommendation for the cancer patient. Initially, the accuracy was 60%, 70%. It was very inspiring. All the global hospitals like MD Anderson, MSK in the US, they adopted this platform. after 2 years, 3 years, and 4 years, and 5 years, this accuracy improved? No, unfortunately not. You know why? Because this company is not healthcare company, it's IT company. And they didn't know how this data, operation data from the hospital was collected. They didn't think it was important. They thought it's just the data. And they got initial accuracy 60-70% good. And they thought they will train the machine like a machine learning, right? Or deep learning. The accuracy will improve, but it didn't improve for next 3-5 years. Eventually, this company had to stop the service. And the hospitals, especially the cancer center that I mentioned, they could not accommodate this because it's less accurate. They were expecting the improvement, but didn't happen. Again, the root cause of this case is how hospital data is operated. They have to know the experience of EMR or PACS, HIS. Without those knowledge and experience, any company who comes in and wants to install their AI or big data platform, eventually you will experience high risk of that. Okay. Moving on to AI, maybe some of you already know this roller coaster AI hype curve. So to say, it's not Philips, by the way. I'm trying to be very neutralized today, so bear with me. This roller coaster AI hype it's one of the industry theory that I prepared this slide today. The reason is to inform you how the AI happened. What I'm trying to say the message using this slide is AI is not just came out of a blue like a smartphone. AI was there back in 1940s when the computer desktop was invented by the software. And when the software, the data was collected using the computer desktop, the IT company, they try to train the AI algorithm at that time. So the curve goes up because, data is collected, let's apply the AI there, but it goes down, right? And it goes up again. The main reason in that timeline for going down and up is when the IT company, they want to apply or develop the AI, they couldn't do it. The main reason was there was so many robust data to swallow, meaning it was so hard to process the machine learning. It's taking long time. Maybe some of you saw one of several American movie. There's lots of server. It's old movie, by the way. It's a supercomputer, they say. And there are lots of servers, right? The reason was at that time, semiconductor, CPU was not well developed. So everyone's training the AI takes so long time. So eventually they dropped. However, they developed and launched the personal computer and the semiconductor got improved. It comes back again, but still that was not enough, goes down again. And then now recently, GPU, I'm sure you heard, it's an advanced version of a CPU, which can process multi times faster in terms of a large amount of the data. So when GPU, NVIDIA, the company called NVIDIA, launched and start supplying GPU in the global market, that's the time when this AI business and AI just kind of skyrocketed. And lots of startups, lots of big players like Google or even Apple, etc., they are developing and investing to apply the AI. That's the history. So AI is not a rocket science. It was there. It's just an algorithm. It's a statistic formula that engineers, data scientists, they apply. It was there. It's just the data processor hardware could not follow the massive amount of the data. So don't get excited when AI is there. That's the history. The last AI is how I receive a question from the clinicians, can AI will eventually replace the doctors? or clinicians or nurses? Definitely no. The reason is there are the gray area, like this slide indicates. The data set is not sufficient to address. And secondly, we are talking about the life or death, the health condition of the human being, right? Of course, we make human error, but we can address that. However, if we leave it onto AI or machine, they cannot address. There is an algorithm, let's say 99% accurate, right? Then 1% mistake, yeah? We use that AI algorithm just by itself. If you have 1 million patients per year, then you automatically know 10,000 of the patient will be misdiagnosed, right? How can you apply? If it's a 99.9% accuracy, then it's a 1,000 patient will be definitely misdiagnosed. Then how can you allow that? How will patient allow that? Nobody will. That's why we need the human clinicians, doctors to co-work with AI, use AI as of a side supporting tool, not for diagnosing or treatment purpose. That's for sure. Okay, so let's get into it. I'll run faster. So I talked about the data, and this is the slide that I was mentioning. It's development of the technology. Not only the data can be collected from the hospital level, but also home level or healthy living level. There are lots of wearable coming up. Again, this data is being collected by hardware. So when you hear about the data collector, the role is taken by hardware. And it's not just Philips, as you see, so many brands, hundreds of brands that even Harapan Kita is currently using and the other hospitals using globally. However, all the vendors has a little difference in terms of a data standardization, how they do the exporting the data to the platform. So all these different color of the lines, arrows, requires different format or different standard. So what Philips thought is, because we know this situation so well, instead of replacing the hardware, right, we decided to develop and provide the platform that can collect not only the Philips brand devices, but also the other brands that the hospitals or clinicians use. And we help them to standardize the data into the vendor neutral universal data management. There are lots of this platform that we provide to the global hospitals so that all this clean and filter data can be used for AI development. So that's our vision and that's our goal. Again, another way to look at it, there are lots of devices and also different brands of EMR or PACS, lab information system, etc. We have the solution that we developed. It took lots of years and lots of investment, but eventually I'll share how we do that. So how we collect those multi-brand device data to this, we have an in-house solution called IntelliBridge. And this already being very commonly used. I think the IntelliBridge is also being used for Harapan Kita as well. And it's all very common, the solution that we develop. It's a proven technology. But if you see, it addresses like 300 plus other brands or other devices only. But hospital use more than 1,000 of the devices and brands. So this is not enough. So what Philips did is we did an M&A. We acquired the company called Capsule. This is USA company. This company has a data integration solution. They're way better than Philips. Philips could only collect 300 devices from multi-brands. This company could collect 1,000 of the devices from multi-brand. So by acquiring or partnering with Capsule, now we are the largest or the best data collection capability we equipped. And Capsule has already been proven technology in the US and Europe for sure. And we already deployed the Capsule solution in Asia Pacific market. So this is very inspiring the initiative that the Philips really successfully do. And when it comes to digitalization for the Harapan Kita, we will definitely introduce furthermore on the Capsule solution. Okay, now the introduction was there for data and AI. Let's move on to the smart hospital. So all this digitalized data will be used for the smart hospital for sure. But now how it's been used in the global market is clinical command center. That's the story that I wanted to share today. Of course, why clinical command center? Purpose is to improve the patient experience, better health outcome, staff experience, and saving cost. But how? Like you see some of the photos, the most comes from the North America, US hospitals. This command center has been used more than 20 years. The main reason is because USA, they already experience lots of healthcare professional resource shortage because the country itself is large, but there are so many population living in different regions, but there are limited number of doctors and nurses. So they kind of brainstorm, ideate how to address this challenge, and they came up with this clinical command center concept. Basically, the command center, only 4 or 5 experts stationed there. When I say experts, senior nurse, senior doctor, who has a very experience and insights. The reason why we station them into the command center is so that they can share those insights with their other department or their partner hospital or network hospital. Like that. So that you don't have to, first, if you can hire, please go ahead. But if because of the scarcity of the resource in these expert clinicians, we station them in the command center so that they can support network hospital. Or you just hire those experts per each of the hospitals. But that's costly. And even in the US, they cannot find expert nurses or doctors. So this is the concept. So, however, the command center itself is not enough because there are so many patients to address. They will be burned out, right? So this is where the solution, the technology comes in. The first stage, collecting all the patient data into one platform, and we apply AI algorithm to monitor the vital sign data, EMR data, and we asked the AI to predict the current status or the future status. So that based on this platform's support, experts in command center can triage the patient who has the highest acuity, who requires the most attention, immediate attention. So instead of doing the rounding for every patient, regardless of the acuity level, you save time. You know which patient to address first or later. You can prioritize on the patient who are in bad condition. So this command center started from ICU 20 years ago. Already 20 years ago. That's amazing, right? But the evolution of the technology, now command center for cardiology, command center for pathology, and command center for radiology is there. So already the world is changing a lot. And if I start with the tele-ICU, the command center, basically again, collecting all the devices, not only from the Philips, but also from other vendors. And we display them in informatics dashboard like that. So experts look at this dashboard, and I'm sure you can intuitively tell the red signs are something triggers, right? Yes. The AI is calculating this customer's status, current status, by and large, based on real-time based vital sign data or EMR data. This is calculating the acuity score, and also it can provide the retrospective review as well, so that you can prioritize your treatment. For instance, all these red dot patients are high acuity. So instead of doing the general rounding, you prioritize the care based on the conditions. Also, there's AI algorithm also supports clinicians when it comes to discharging from ICU to general ward. Now this algorithm got so much trained with lots of patient data. The accuracy level is 98% or a little higher, but still it's less than 2%. It's not perfect. So at the end of the day, clinicians, doctors, they use benchmark the AI results so that they make a decision. Now the mobility. Now I think we are the only vendor, yes. We are the only vendor who applies to provide you the application in your smartphone to monitor the vital sign. When you're away or if you are taking a break, you can transfer the alarms to your colleagues who are at the bedside. So using this platform, there are lots of white paper, clinical paper published, especially from the US, because they've been using this solution for 20 years. One of the case I brought here is UMass Memorial in Massachusetts, and they have a 4 hospital connected. And this is one of their white paper that I captured. It's not Philips report, by the way. And in the left-hand side is before tele-ICU command center. The right-hand side is after the tele-ICU command center. And all this black dot is a number of the patient case volume increase. The main reason is there's always expert ready to support bedside clinicians with high insights and expertise. So care quality level increase, so the length of stay decrease. And then the patient can, discharge faster. And this command center, by the way, is for Asia Pacific wide. Australia is adopting this rapidly. And they are connecting multi-sites across their continent to support and share their expertise with the bedside nurses and doctors. Another clinical outcome, it's also again from JAMA, Journal of American Medicine Association. It's not Philips data again, but this is the average. Having this clinical command center helping the bedside clinician, they could reduce average of 26% of mortality rate, and also reduce 20% average of a length of stay, malpractice, 90%, because there's always senior nurse or senior doctor can help 24/7 when the help is needed. Okay, moving on to the cardiology smart hospital. Look how many product and software that this is for Philips product only, but there are more brands, more hardware and software that you use in your treatment or the intervention room, etc., right? So many devices and software. And this is the photo, one of the photo from a Japanese cath lab. You see all those monitors with the different desktops, because softwares are all different brands. So all different brands, the cardiologists and the doctors, they have to use to analyze their patient condition, do the planning, procedures, etc. So one case requires multi-softwares, very inefficient. So what we launched 5-6 years ago already is called the cardiology platform. We call ISCV, and it is connected with the multi-brand vendor-neutral softwares and also devices. And looks like this. It's like a mini EMR that you can use. And it provides very comprehensive data so that you can communicate, collaborate the clinical and the treatment actions. And rising number of cardiac patients is same globally. And this is the Spain case, the public hospital group, because they could not find the cardiologists, echo, the nurses, they used this platform to connect, I think it was 90 hospitals to do the command center, sharing the expertise. Saudi Arabia, I'm sure you know, they import the doctors and nurses. It's hard to find local doctors. So when they launched their government public hospital, they wanted to connect the cardiac center. Yeah. So it's not that easy. It's not that difficult to understand. It's very conceptually, I hope it's easy for you. And the radiology department. By the way, there are lots of other Asian countries shortage in the radiologists and the radiographer. And what we are providing, by the way, these solutions are not launched in Asian Pacific yet. It's more the very recent technology that I'm sharing. It's mostly deployed in the US. We connect all the MRI, CT, X-ray, everything, modality, to one platform. So that the command center, again, the senior radiographer, senior radiologist, they station there and support the scanning room staff. If it's a junior, if it's a newcomer, our technology allows to do the protocol sequence setting too. So it's not just talking. You can control the sequence for MR scan or CT scan based on the body parts and the conditions. If it's required, how efficient it would be. This is command center connected to the MRI room. So it provides really good efficiency and also the training so that you reduce the rescan for sure. And this is the case that they could expand the radiology scanning, having the command center support 24/7. And also the downtime, the rescan rate came down. This is a British case and expanding. And also the radiology, they also use advanced visualization tools, what we call it workstation software, to analyze the symptoms and the conditions. And because of the shortage in the radiologists, look at these hospitals. They're sharing the expertise of the senior radiology with the multi-hospitals. They're helping each other. And one of the USA, the Augusta University case, they have 4 hospitals network and one standardized workflow. They could increase 17% of the procedure volumes and decrease the turnaround time. So it's not only good for the radiographer or radiologist, but also good for the patients as well. Another one is the dashboard, which provides the operational status of your hospital. Let's say, what is the waiting time for your patient when they arrive? We want to monitor that. And we capture and transformate the waiting time or the delay, how the machinery modality is being used, the performance-wise, why it's a breakdown, etc. So this is not medical area. This is more on your hospital operation, monitoring, and utilizing your modality that you purchase, optimizing. And having all this data by month or quarterly base or year over year, you see here, the exam volume forecasting, that's AI will help you. Why there is a spike of a number of a patient in that month or in that quarter, you can analyze easily. And based on the data, AI will tell you, oh, this is the time maybe you need extra resource. But this is the time maybe you don't need to extra resource. You can review this and optimize the resource investment. Okay, so lots of hospitals are using this. And the last one is a pathology. I know the pathology may not be a big interest, so I'll go very quick. It's a biopsy tissue, the cancer tissue on the glass, and the pathologists, they read, analyze from the microscope. But we scan this biopsy tissue and make it as of a digitalized image so that you don't have to use the microscope anymore. And lots of hospitals are adopting this because, for instance, in the old days, X-ray, there was a film. It became PACS. So digital pathology, it was the slides. Now it's digitalized image. Of course, the image quality is equivalent to the microscope. By the way, lots of these hospitals are replacing the microscope with the digital pathology solutions. And there are AI supporting. For instance, in pathology, they cell count the tumor cells, but that's manual job. It's very hard, time consuming, but AI helps auto counting. And also it provides the region of the tumor as well. This is AI, and this provides us a very good efficiency for the pathology department. See the left-hand side, the current manual way using microscope. Right-hand side, digital pathology with AI. And there is one JAMA report, clinical report, saying, oh, digitalization saved the cost and the time and more cases. And now this digital pathology is also very big shortage globally. So they need a connecting solution by hospital to hospital. And the reason why I show you this is pathology image, one file size is gigabyte. MRI, less than megabyte level. But the pathology image file size is gigabyte. So the reason why I tell you this is when you want to share pathology image with the other hospital and you have to zoom in, zoom out, it's like watching YouTube, yeah? Sometimes there is a break. Sometimes there is a lagging because it's a high data volume it's transmitting, yeah? So when it comes to network solution, it has to optimize high volume of the data so that sometimes, by the way, Teams or Zoom, they lag, right? The images or visualization lag. It's a data management solution, it's lacking. But we do have that for no lagging and very efficient. Granada Hospital in Spain already connected 4 hospitals to optimize the pathology resource. Even in Netherlands, 3 competing, they're competitor hospitals, but they decided to share the experts because there's such a big shortage in Netherlands for pathologists. IDEX, it's an international veterinary healthcare network. Look how many sites connected. Okay, so for the first section that I prepared, this is the summary, the command center for the network hospital. And eventually, the design of the command center also has to come from each of the hospital, like Harapan Kita, what's your vision, what's your strategy. Based on that, we can help co-designing the command center. This is one of the example. For instance, each of the tent that you see is a hub, and it can be emergency, it can be ICU, it can be general ward, or it could be department level. So we can co-design and optimize the command center as well. By the way, it's the real photo from Westchester Medical Center in the New York State. They started from 3 network hospital. Now they expanded to support 8 network hospital in the region with this command center. So many products you should consider when adopting. So I'm not going to go over today, but just wanted to show you the future. Eventually, starting the data collection from your hospital, main hospital first, and the second phase, network hospital, and enlarge the network hospital. And eventually, if the technology is there, the smart city. So that you provide a high level of care quality to more addressing bigger population. That's the concept. Okay, I'll pause here because this is the end of my first session. By the way, the second session will be shorter. The third session will be much shorter. So bear with me. If you have any questions, feel free to ask.
Oke, jadi allow me to use bahasa first. Jadi silakan Bapak Ibu untuk memberikan pertanyaan. Kita berikan ruang mungkin 5-10 menit karena ini banyak presentasinya. Mungkin 5 menit. Persilakan. Jika ada yang ingin bertanya terkait yang sudah dipaparkan dengan Mr. Kevin Kim, dipersilakan. Ada Bapak Ibu? Oh boleh, silakan Pak Anwar. Ya, monggo.
In case of a system shutdown, how would the backup system do data? And second, how to recall the data for the research purpose? Thank you.
Sorry, beg pardon for the second question.
First, about any system shutdown.
If there are any shutdown, how to operate or how to handle it.
Backup data.
Yes.
And second, about for research purpose, how to recall the data for research.
For the publisher?
Yeah, untuk kebutuhan.
Oh, for the research. As for the research, so how to gather data from the smart hospital system?
Yes, so thank you for your question. And the first one, the shutdown. Fortunately, we haven't experienced any shutdown yet, fortunately. It's due to our platform is also connected with the hospital platform, HIS, Hospital Information System, your EMR, your PACS. So unless hospital system shut down, our platform will never shut down.
Okay.
So it depends more on the hospital network. Okay, because again, if you remember my earlier slide, we are providing like a midway platform. We are not replacing your EMR or PACS. No, we connect and we engineer easier dashboard or connected, utilizing all your hospital data. Clear? Second one was the research.
Yeah, for the research purpose.
Yes.
How to gather the data.
Yes. Thank you for asking. I was considering if to add that part or not. We see there are 2 research you can conduct, obviously. One is clinical research. Second is technology research. The first, clinical research, because all the patient data will be stored at the big data platform that we provide you. You can conduct retrospective research or clinical research. Or, for instance, the new medicine, new treatment, you can see what happened to the patient because the data is not just collected, there's a timeline, day or minute, hour timeline, so that you can immediately check. So very easy. And also you can export the data based on the needs of your clinical research topic. Secondly, technology, digital research, I would say. It's more AI. So when you want to develop AI, you need a data set. It becomes, you can download based on the patient profile, conditions, or age group, you can filter. It's so easy. So based on the AI algorithm, let's say cardiac arrest early detection, right? So then you select and filter the case of a cardiac arrest cases, and you download that. Like I said earlier, our data provides a timeline. Yeah, before cardiac arrest, what was the vital sign? What was the ECG? And all these data scientists or AI algorithm development, they use those retrospective data. And then suddenly there's a timeline, red alarm, right? Code blue, cardiac arrest. So we train the algorithm like that to develop initial AI. And then later, once the first AI is there, you apply that AI into this data platform for validation. If this algorithm is accurate or not. If it's less accurate, then you tell the data scientist to make improvement. You think the connection correlation of the certain data vital sign is not right. So ask them to refine the formula, the coding, and then you also do the validation again. So many times of a clinical validation you can use using this big data platform. Is it helpful? Okay. By the way, in terms of a research, USA, they have, for instance, ICU patient data, government funded, big data platform. They made, it's called Mimic. And it's a fourth generation already. By the way, that government-funded big data platform was so successful, even Korean doctors, Korean startups, they use American patient data.
And using Philips?
It was also co-developed.
Co-developed.
We were one of the...
So the Mimic's co-developed.
Mimic was, we were the one of the, as of a technology provider. Mimic is also Harvard Med, MIT, and Philips. So 3 players. And recently, 2 years ago, Korea MOH wanted to have a Korea patient data like Mimic. So they invited 16 university hospitals, 5 local IT or EMR brand, about 10 plus Korean AI startups. And they're funding $40 million
US dollar
to collect the data first. And collected data, the AI startups, they collaborate with the clinicians to develop the AI algorithm. So the reason why I tell you this is my strong recommendation for Harapan Kita, since it's a public hospital, it would be good to generate the cardiac patient data, big data platform, of course, hopefully funded by your MOH, but data is the asset. AI is not an asset. Don't get confused from the media that AI, mostly, unfortunately, garbage. It's not proven.
Thank you so much. So the data is the #1 priority. It's very super important.
Super important. You have to invest in data, and then you hire AI startups. That's easy. There are so many AI startups, but once the data is wrong, nothing going, forward.
Yes. Okay. Interesting. Sufficient. Okay. Any question? Okay. Ya, Bu Sri Martinisi, silakan.
Sorry.
Yes. Jangan aja.
Baik, terima kasih dalam bahasa Indonesia ya. Pertanyaan saya, terima kasih presentasinya sangat bagus.
The presentation is very good.
Ya, jadi yang saya tanyakan adalah ini untuk
So what I'm trying to ask is,
untuk rumah sakit yang akan dibangun kemudian atau bisa menggunakan teknologi yang sudah ada saat ini.
okay, is this for a new hospital? The system is it for the new hospital we're going to build, or for the existing? It's can also, and then and for a clinical command center. Is it utilized for? Yeah.
It's unit.
Is it utilized for each unit, like only for cath lab and then ICU and then who's responsible? Is it the doctor responsible or for the patient or the management? Okay.
Thank you. I understand your
Yeah.
question. Thanks. First,
Oh,
yeah, satu
another
lagi.
question. Yes. How the confidentiality of the data and how to store the data. Okay.
Thank you. Thank you
Patient
for
the patient data. Yeah, for the patient data.
Thank you for the question. Very, very good question, by the way. First, deployment of all the new technology. Of course, the new hospital is easy, as you can imagine, yeah? You just pick and choose. You prioritize. There are so many. So second session, I'll talk about how you prioritize your solution. But there are thousands of hospital wants to do the digital transformation, wants to have the command center. Earlier slide, if I may jump. Okay. If you see here, US case. Okay. So it's too far away. Oh, there you go. So it's this hospital could be a best case. Yeah. The Veterans Affairs, they have 1,700 sites in the US. Yeah. It's not new. Everything exists. The reason why they wanted to have a command center is because of the COVID-19. They want the experts to help the 1,700 sites with the existing EMR or PACS. So what we do is our engineering team, our network and service team, they visit and check the status of your system, EMR or PACS or network, etc. And we try to optimize and provide you solutions which is possible or not possible. But mostly, it was possible so far for Philips. Rarely, less than 10%, not possible. If it's due to the EMR, if it's outdated, it's too local and basic version, and could not find the solution. Very rare case. So that's one. Secondly, about the clinical command center, I think it was on the responsibility.
Yes.
Yes. Very good question. So when we deploy command center, to be very honest with you, 20 years ago in the US, we received complaint from our American customers because no R&R, no workflow. It's just experts sitting there watching data. That's it. And millions of dollars they invest, big money invested. So that's 20 years ago. So at that time, we learned this kind of a new technology requires consulting, designing the workflow, designing the process, and R&R is required. And also all this designing is different by hospital because the governance, your KPI is not same. Of course, a similar, but not exactly same. So our team, we decided to have a business team unit called the consulting. And by the way, the second session is about that experience. So we help you to optimize the new R&R and workflow so that this discrepancy or risk can be minimized. By the way, it cannot be solved in 3 months or 6 months. Requires lots of exercise together. Like a year, after a year, it will be stabilized because it requires some training too for the nurses or doctors in the bedside as well, because they will be using two-way audio video solution on top of the data. So as a matter of fact, in one of the institution in America, they already have training center for command center. If they want to, this hospital started from 3, 5, 20 years ago. Now, 30 hospitals support. So if it's a new hospital without this command center, they invite them to their training center and you practice the two-way audio with the command center and all that. That's another. The last one is the confidentiality of the patient data. Very good question. Basically, I think it's not just us. There are lots of solutions that kind of protects the confidentiality, anonymize the patient profile, name especially. But rest of the data is there, the condition and all that, age and all the basic data are there. How normally collect for the research purpose is, I mean, all the time when you admit the patient, you ask the patient or family to sign the consent, right? So you just, our recommendation, the easiest way is when they do the administrative work, you just add another column that we will use your data, of course, anonymized without the name, for the clinical or technical research. Normally, patients, if that's the purpose, they check consent. And all the data can be without the name or the number. Yeah, you can filter the data based on the age group or sex or the symptoms, etc.
Okay.
That's how the research is conducted.
Is that enough? Okay. Thank you. Thank you so much. Let's have a round of applause to Mr. Kevin for the session first, for the first session. Okay. Moving on, we are going to have the second session. It's a co-creating smart hospital and reference case.
Give me 1 second. Let me switch to the other.
Dimohon untuk mengisi daftar hadir Bapak Ibu lewat QR code yang sudah ada ya.
Okay, so I think we already touched base on, I think it was helpful for the smart hospital reference cases and some of the solutions being used globally. But earlier session, there was some question related to this part. So there are so many solutions, how you pick and choose, how you deploy, etc. So we, for Philips, again, what I can tell you with full confidence is we do not have the answers, let's put it in that way. But we have an experience helping the hospitals, clinicians like you. And for that approach, we use co-creating, not, of course, we help you a little, but it's not Philips. We help your team, let's put it in that way. Because in the hospital, there are multi-department, multi-roles, multi-clinic doctors and nurses, and administration, biomeds, multi-department roles. You are the experts. You have all the big data. So we help you to collect the data and co-create and design your smart hospital for Harapan Kita. Let's put it in that way. And how we do it, I'll show you. Oh, it's not working. And again, I said earlier, for the 20 years ago, all right. We started this smart hospital digital transformation 20 years ago from the United States, and then moving on, expanding to the Europe and also to Asia Pacific. Almost conducted 200 and plus projects to digitalize not only the new hospital, but also the existing hospitals. And from there, we experienced that everybody thinks smart hospital is about the technology. But this is only just one part. Technology is not smart hospital. Again, I like to stress this. Smart hospital is more how the hospital sets the vision and strategy. It's not driven by AI. It's not about robot. It's not wearable. It's more it should be more focused on how you want to digitalize, how you want to create smart hospital. Let's say for Harapan Kita, I think Mr. President, before my session, he shared some of the vision and strategy of Harapan Kita. I was very inspired to see that because it was very realistic, very pragmatic. So that's important. So I'm glad you have that equipped. And also the governance, you have to implement. Technologies are just a piece of the puzzle. The users like you have to be comfortable, confident, and easy to use this and apply this to your patient care workflow. That's more important. Like I said, American Hospital adopting command center tele-ICU solution. They complained to us because clinicians did not use, no new workflow, no process was missing. So it was a failure case. So the key success factor of the smart hospital is not, again, technology, it's you. The management of the hospital and clinicians and nurses, it's all you, how to use that well. And definitely we will support you there from our experience and also the insights that we got from the global cases. Having said that, co-create approach. This is the Philips co-create approach. And I kind of prepared based on the case, the real world case today, so that you can easily understand. The first one is setting the vision and strategy again. How we help is utilizing the global cases like this. J hospital, B hospital, U hospital. We help you, we analyze existing vision and strategy, because we learned that all the time the vision and strategy is everything is so good, so wide, so many. The part that we help you is prioritizing among the vision, among the strategies, how we help you to prioritize. So for instance, the J hospital, it says this hospital turned out to be the best value that they want to focus is clinical outcome. The B hospital, the best value they want to generate focus was patient experience. The U hospital, they want to do everything well. It's lots of Korean hospitals like that, U hospital, but I don't know how Indonesian hospital is. Everybody wants to do like that, but it's tough. That's the toughest. Later you will understand. So once this, by setting the priority value here, later, this will be a ground rule when it comes to prioritization. And I'll remind you on this again. Second, you have to know your existing problems, your challenges in terms of patient, family perspective, and also in terms of a clinician's and nurse's perspective. You see, it's hard to read. These are the patient profile. Each of the color represents patient profile. For instance, old age. For instance, pediatric patient. It could be emergency trauma patient. It could be outpatient. So we separate that. And each of the color boxes is patient journey. So we guide you to think about, put yourself in the patient or the family perspective when you park your car or when you arrive at the main gate. How is your experience in terms of admission or waiting, going to the test labs, or admitting to the ward or discharge? So all this is based on the patient journey base. And we ask you to share your experience, your idea for each of the steps. These are the problems, I think. That are the problems, I think. You're sharing your big data. How Philips help is we help to consolidate, because there will be some common challenges or problems that you indicate, right? So we get all the big data using the patient journey, each of the stage, you provide all the big data, problem and challenges, and we optimize and consolidate. Because we need those, because smart hospital need to address the existing problem and challenge first. The reason why I stress the existing is I experience lots of hospital, they overlook existing problem. They just want to have fancy AI or robot or address one or two problems. In this approach, you can address later multi-problems and you can prioritize. We'll come back to this prioritization later. And then here are the new technology. By the way, all this technology is not Philips. Less than 10% is Philips. So we don't put the brand there, right? But like a robot, AI, facial recognition, automation, and all that. There are so many technologies. Then how do you prioritize when selecting? Because we all have limited budget, limited financial money. We want to buy everything, but we don't have money. How we prioritize? Coming back to the first stage, the vision and strategy. We set the ground rule there. So we filter the prioritization here, right? And secondly, we did a drill down of the challenges and problem based on the patient journey. Which solution can address multi-question problems at one time? So that's another criteria we can apply. So optimizing your limited budget to address multi-problems and challenges. That's our recommendation. And also deployment. We need to check. We will send you the expertise, whichever the technology you selected. It may require some of the servers, sensors, storage, all that. So we will diagnose your existing hospital, the spacing and all that, and optimize for deployment. Workflow comes here. This is a sample case for digital pathology, by the way. This hospital replaced all the microscope and installed the digital pathology. So the work environment is totally different. And we are not, I think, when it comes to, again, reminder, when you want to invest on digital solution, ask them if they can support you in terms of redesigning the workflow, because that's the most important that I want to stress. We know the importance. That's why we have an experts at Philips. And these are the flow chart of the new workflow. And of course, this is not solution. We visit every 3 months. If this new workflow works or not, we receive a feedback from the users, clinicians, and we refine the workflow again, and we monitor for another 3 months, refine, and then optimize, and we fly through. That's how we provide the technology and set up the new workflow. This is one of the sample case. So when it comes to designing or co-creating smart hospital, we have a two solution that we pretty much provide you: the digital health maturity assessment and also the co-create workshop. And I'll briefly share what this is. Digital health maturity assessment is a survey that we provide, or we utilize this tool to examine your digital maturity level in terms of a digitalization. Like, for instance, are you happy? Do you have EMR? These PACS. Is your EMR connecting to the devices and all the data is updated? Something like that. And this digital health, we diagnose in three aspects. The first one is operational assessment. When operation, it's in terms of a hospital management, the flow management and all that. We have a questionnaire, and there are 5 stages that you can scale. Of course, the survey is anonymized. Your name will not be there for sure. And you kind of check the things that you feel your hospital level is. So we collect all those data and summarize and provide. And also clinical level is how are the digital solutions or tools implemented in our hospital in terms of a clinical patient care perspective. The last one is experience. Do we have, for instance, digitalize a kiosk that patient or family can do the admission or payment, things like that for the workflow. And also operational efficiency, it's like a robot, but things like that, we have to know where we are first. This is how the tool is being used. And later, once we have all those data result, we ask you, where is the future of your hospital that you want to prioritize? Of course, everybody will say stage 5. That's not acceptable. We kind of do a voting way. For instance, we give you a votes and you just vote. There are 27 elements in this survey assessment. So you vote top 3 from your view, your department, it could be whatever. So that we prioritize which area the hospital can invest in phase 1 and what's phase 2 and what's phase 3. Co-create methodology, again, it's simple. It's a 4 steps. The first is a discovery. Discovery in terms of what vision and strategy and where we are in terms of a hospital level. Framing is the challenges and problems that you experience, that we kind of consolidate those challenges and problems to address. And ideate is what are the digital solution can address those problems. And then build this with deployment. Of course, we have to prioritize the solutions and then we deploy. It's very simple. This is conducted through a workshop manner. And this is great because we use a Post-its so that the junior level or other administrative team can share their thoughts without, considering the hierarchy or political aspects. So that's why it helps to do bottom-up approach as well. And this is very important. Bottom-up is really, really necessary. Normally, from the globe, lots of top-down approach for smart hospital and digitalization. But the downside is if you do that, it's fine. But downside is implementation and execution or using the solution is very low interest from the users like you. So if you want to motivate the users to fully utilize the new technology that you invest, you need to listen to their voice. What's their problem from their view, challenges, and make the investment decision from the top management based on the report. So that once the technology is selected and deployed at the bedside level or hospital real world level, Oh, okay, I know. This is why I adopted. I know the purpose and background. Okay, let's try using it. They are motivated, energized, instead of just top-down manner. So this approach really gives you the fast adaptation level and low resistance as well. Workshop, some of the photos, how it is being done, we carefully pick and select like a senior members or junior members from multi-different teams. We carefully select. Unfortunately, we can accommodate like hundreds. So we will be doing a representative selection so that all the department's voice as much as possible is being heard. Of course, the outcome report will be shared throughout the hospital level later. And agenda 2-day workshop is pretty much good to accommodate. Sample case. So this is the drawing that we bring for the workshop. It's hard to read, so I will tell you. The top line, admission, diagnose, treatment, recovery, and discharge. So we have this design, each of the stage from patient's perspective or family, and also clinicians or nurses' perspective. What are the challenges? We ask you to share your big data from your view. It does not need to represent the hospital, your view, because you are already part of the hospital, regardless of the department or role. Your data, your perspective is important. So we ask you to paste everything like that. And we help you to summarize like that later. And we also kind of help you to pick top 10 burning issue. There are so many issues to address, by the way. So we ask you to pick and select, vote the top 10 burning. All the time, the smart hospital, prioritization, prioritization, prioritization. Remember that, please. And also the opportunities as well. And ideation. What are the solutions? So we don't just ask you to pick and select and share your thoughts. No, it's not like that. We want to be professional, right? So we are leveraging the patient journey again. On top line, admission, diagnose, treatment, recovery, and discharge. We kind of grouped it into 3 categories. And then we ask you to pick and select to address those, each of the problem in terms of 3 categories. This is the operational efficiency. And same way for clinical purpose. So if I come back to the operation efficiency, it could be the data management platform. Let's see. It could be dashboards. It could be patient monitoring or VR training, medication dispensers, automated, things like that, operational. Clinical, it's AI, like a pathology AI or radiology AI. It could be the mobile ultrasound. And command center falls into the clinical excellence as well. Experience centricity. It could be the robot transporting the food and the laundry, etc. It could be AI speaker. It could be kiosk. It could be a navigator. Some of the hospitals says, well, our old building hospital is so complex, they need a navigator to find each of the department or payment station, etc. So things like that. And then if we put all those solutions, there are so many solutions you can pick and choose, right? And then we do a prioritization at the end, again, considering the vision, strategy, and priority on the focus area, and also the top 10 burning issue of the challenge and problem. And for this case, it was a 3-year plan. It was done back in 2019. And surprisingly, this hospital implemented 90% of the solution during past 3 years. Really surprising. And they are doing the second roadmap for next 3 years, next week. The reason they could do this well is acceptance level of the clinicians and nurses from the hospital, because they could share all their thoughts when planning this, what you just saw. So when hospital management invest in year 1, year 2, year 3 like that, lots of doctors or nurses, lots of teams, they well adopted. They actively used so that they could move on to the year 2 and they can move on to the year 3. Of course, next week, when we do another workshop with this hospital, they will evaluate. Was it really satisfying? All those, they deployed the 20 plus solutions. By the way, 20 plus solution, only 3 solutions from Philips. Rest comes from local brand or newly developed. Like a real-time location tracker. It was a hospital and the local company co-developed. Some technology comes from Philips. And what I'm trying to tell you is this kind of approach, it's not just Philips that we are trying to sell. It's very small portion. Rest will address from newly developed or it's interesting. They deploy 20 plus. We will review, we'll ask the stakeholder participants of the workshop, tell us your difficulty using those new technology. We will revisit them again and ask them what can be better? What's your request for those existing solutions to be upgraded? And then we go on to the next 3-year planning with additional solution deployment. Okay, we've done this lots. I'm mindful of the time, so moving quickly. We've done, again, lots of this co-create, and also in Korea, Seoul National University, Severance, Assam Medical, we already conducted. And we are expanding this service to the Asian Pacific. I mean, Australia already adopted. And we deployed this co-create approach, I think 2 months ago in Indonesia with other hospital customer. And also we are getting lots of requests on this approach. The last slide for co-create session is, again, you have to break the wall. Our experience, you have to break the wall between the department and also be collaborative, regardless of your role, R&R. The more you do, the faster the transformation will happen. And try to see, even you are in specific role, even you are in specific team or department, but try to see the big picture of your hospital. You yourself, our recommendation is you yourself try to be like a CEO. See it as like a CEO of the hospital. And look at the problems and challenges. And also consider your limited budget and prioritize. And when it's deployed, try to collaborate. The reason I stress on collaborative and break the silo is these solutions that whichever the hospital select, there are solutions only specified for the departments, but mostly they will address multi-departments, multi-roles. So you'll be sharing all those technology eventually. So you definitely need collaborative manner when it comes to the smart hospital. Again, technology is not smart hospital. It's the people, the governance, collaboration. That's the key success of the smart hospital. That's pretty much it for the co-create session. Open for any question you may have.
For the time being, can you just continue to the third session? So the question will be implied later after all the sessions.
Digital twin is somewhat simple and easier because it's a new technology. A second. So it's a really appreciate your time today. And I know it's so hard to gather all the doctors and nurses and managers from the hospital in one day. That's why I kind of wanted to share the future technology as of a closing session. It's a digital twin. I'm not sure you're familiar with this terminology. It's a very new terminology, but from the word itself, maybe you can imagine, right? So digital twin is basically we are replicating the real world. It could be city, it could be hospital, it could be patient. Replicating the system itself, infra real world itself, into the digital world, the interface, like a web base. It could be the metaverse, and it can be real virtual reality, AR, the augmented reality as well, because it replicates in terms of our VR or AR. But let me start with the hospital level first. Lots of people are focused in digital twin for the hospital level. By the way, this is a blood sampling lab. There are 2 labs here, and there are the sitting area, administrative area like that. And then we apply the time the patient spend at the admission desk or waiting and walking there, and also achieving the blood and coming back and waiting. We apply that. And there's a simulator we apply from 9, for instance, 8 to 4. 8 a.m. to 4 p.m. How many patients can be seen with this design of the blood sampling lab? And how many seats required? You can simulate everything. And if the time is too high, and if the patient number of the patient is too low, then we ask to redesign. Without having this tool, how can you estimate how many patients you can do the blood sampling? How many seats you can prepare, the space for the seats? And how do you know how long the patient have to walk and come back? So all that can be prepared having this kind of a digital twin simulation. Another sample, it's a department level. It's based on the emergency department sampling. So there are admission, waiting, checking, triage, all the sections are there. And if that's the infrastructure, how many patients can we see? Is it seat enough for the patient's family? And we can also change the design and see if we can accept more patients at the emergency room. If with the new design, we can simulate that. And also scanning room, same. MRI CT room, there are lots of wait time. Patient wait. Because there are lots of rescans sometimes we need to do and all that. But what is the best way to use the hospital space and also the patient to move less and optimize the throughput? Again, what is the optimized design? City level. If you want to optimize your new hospital's location in the region, right? Of course, there will be lots of primary care center or GP and all that. And you kind of simulate, okay, this is the location. How far is it? We add the population there for each of the towns, and we can simulate, this location is best in terms of transportation time from major population and all that. You can simulate. So the reason why I shared, we do not do the hospital or department or design simulation service anymore, but we know the partners who can do. Where Philips' focus is, we call it medical digital twin. Now it's more patient level. And now we want to digitalize the patient with all the real world based lab data, EMR data, and also the organ anatomy scan data together and place that person in the metaverse. And why we do that is once you have the digitalized patient in the metaverse, you can simulate the treatment, how to do the procedures, later how to apply the pharmacy, new medicines. You can simulate. Of course, you don't have to use this medical twin every time. It's purpose for the more complicated cases or procedure-wise high risk procedure. You can apply the simulation so that you know the probability of the risk for that procedure. This requires lots of image data from radiology department, like MR, CT, ultrasound, and X-ray. Because it's a composition, we have to fusion the anatomy scanned image and also connect those images with the EMR lab data. And we do the 3D virtualization solution, which comes from our partner, not us, unfortunately. And then develop this digital world-based anatomy 3D live image so that clinicians can apply the treatment simulation. Another type of the digital twin is using the HoloLens. And you are seeing this digital twin platform is connected to the Echo, NGO, and also patient monitor. It's a virtual reality based digital twin. So on the right-hand side, this photo, if you look at closer, there's a blue and yellow sign. It's an indicator of possibility of the burst or risk. Let's put it in that way. So normally you're using this platform to assess the risk for the complicated high-risk procedures. So you can simulate, oh, is this vessel right way to conduct the intervention or not? And AI kind of provides you the probability. Okay. Commercially available right now, again, this is augmented reality, AR. Why? Because if you see the background image is an X-ray image, but Echo comes in 3D. So Echo is playing augmented reality role, also applied with the X-ray image behind. The reason why we provide you this is when it comes to procedure planning, all the photos are two-dimensional. So doctors, cardiologists, interventionists, it's hard to really accurately plan the procedure with the 2D images. So giving you the 3D base, it's a more realistic image. So the accuracy of the procedure planning goes up. Another one is Echo Navigator. So Echo data and NGO data we combine. You see, this is another augmented reality digital twin. X-ray image behind and Echo comes up as about 3D augmented reality. This is another case for digital twin. By the way, Heart Navigator and Echo Navigator is commercially available from Philips. The earlier HoloLens, that's still work in process, R&D stage. And also this digital twin technology is so complicated and difficult. We partner with the startups or advanced companies in Europe. Also, there was already research conducted in Europe. It's a consortium. It's fusioning the images. And then it allows to support the ablation planning simulation. And we were also part of the company. And also if you fuse an MR, CT, X-ray image and make a real world person, and if you apply, okay, if this person walks for next 5 years, when is the possibility of the fracture? Based on those prediction, doctors, surgeons can recommend patient, let's replace or let's conduct a surgeon this year because the prediction is high, I also thought, etc. Something like that. There's also the neurology twin already being implemented in the Europe and US. They're collecting the data to address the Alzheimer disease. So they're collecting, again, data. This is only the data phase that they are deploying. Once the data is there, they will go to the second phase for the AI algorithm. Future EMR, I kind of designed as of a future EMR. And you can kind of pull up the image data and also apply the treatment, and it provides the simulation. That's pretty much it, yeah, for the digital twin. Yes, thank you.
Okay, thank you so much, Mr. Kevin. Is there any question? Let's open for the discussion. Is there any question? Yes, Mr. Harudin.
Terima kasih, thank you, Mr. Kevin. Yang paling penting menurut saya adalah selain presentasinya ya,
The most important thing for me is beside the presentation
adalah key success dari implementasi digital transformation in the hospital.
implementation of key success of the digital transformation.
Ya, tadi disampaikan Amerika, Eropa, Asia Pasifik sudah banyak menggunakan teknologi ini.
You've mentioned the United States, America, Europe, and other region is already successful using this application or system.
Yang belum terungkap atau yang belum disampaikan adalah sebenarnya kami ingin tahu sebenarnya dari pengalaman Mr. Kevin dalam transformasi digital hospital ini sebenarnya adalah kunci sukses rumah sakit melakukan transformasinya. Karena tadi disampaikan bahwa smart hospital bukan hanya new teknologi, tapi ada vision, strategi, kemudian culture and mindset, dan lain sebagainya. Mungkin dari pengalaman itu kita bisa tahu, ntar kamu translate ya.
Okay.
Yeah.
What we really want to know is the key success. You have already mentioned about the excellence, the people, the etc. So what is the key success for us as the hospital?
Oke, yang kedua.
And then the second question.
Ya, dari pengalaman Mr. Kevin, berapa lama rata-rata sebenarnya harus sebuah rumah sakit melakukan proses transformasi dari manual proses bisnis ke digital transformation itu?
For your experience, how many or how long will be the transformation took place using the whole this kind of system from the manual or existing right now into your kind of system?
Oke, yang ketiga.
And the third question is?
I have a question.
Oh, yeah,
yang ketiga, berapa besar biaya investasi untuk satu commander?
Satu apa, Pak?
Satu commander tadi.
Oh, commander, clinic commander. Okay.
Like
how much the
pathology
investment
command
for one
center gitu.
Clinical commander you've mentioned before. Okay, maybe you can mention how much the investment. Yes.
Okay.
One clinical commander.
Last question.
And the fourth question is?
Jika hanya memiliki dua pilihan, dua opsi antara melakukan transformasi budaya dan mindset, dan pilihan kedua adalah menggunakan platform ini, menurut Mr. Kevin, yang mana yang disarankan? Lakukan transformasi budaya dan mindset dahulu, kemudian menggunakan ini, atau menggunakan ini plus berjalan bersamaan dengan proses transformasi internal.
Pelan-pelan ya, Pak.
Ya.
For your experience.
Itu saya pakai bahasa Inggris saja.
For your experience, which one is better, or which one from these two options? For the options. Yang apa, Pak? Tadi.
Apa yang akan dipilih berdasarkan what you suggest about the one option, first option and second option?
Yeah, what?
First option, internal transformation, like culture, organization, and mindset, or buying the platform. Yeah.
Transformation first from the culture,
Yeah.
or adopting this first and then transforming the culture. Okay.
Yeah.
Or paralleling together. Okay.
Yeah.
Yes.
Thank
The
you, sir.
difficult option. No option.
No,
Yeah.
it's I
That's the
really
option. Yes.
yes. Thank you, sir. Really good question, which I kind of did not address, but really appreciate you bring this up. The first one I think was
I already forgot.
let me first what I remember. I think because this applies in harmonized way. It's not fragmented, it's connected. Let me put it in that way. For instance, from technology perspective, like command center, you asked the cost.
Yes.
What we experienced, I mean, even from the US, right? They started from central monitoring only. And I think maybe I have to double check, but central monitoring solution, hospital scale like this, I assume you have. I assume. But if you're not, it's just a upgrade. It's not that costly. So what I'm trying to tell you is this transformation in terms of a technology with your existing product and solution that you equipped, we can propose as of a phase one that with the minimum investment that you can consider, we can propose this can be done. The reason why I tell you this is there is other hospitals that I'm already aware. I mean, lots of American hospitals, by the way, they started like that, like a step-by-step level. All the dashboard that I show you is the latest, the most expensive one. First generation, for instance, like a tele-ICU or a rapid response team, they started just using the central monitoring platform, connecting multi-network. And also you can pull up their EMR on the site, right? So that's the first generation we can do. And I can combine that story to your culture and all that workflow, because starting from small, the team can go through the learning curve and training and get adopted to this new model of a technology-based smart hospital. Of course, if we have a lot of budget, we can purchase millions of dollars of solution and make it fancy. But is it really necessary? Because at the end of the day, you go through the same curve, the training, refining workflow, R&R, same thing, right? Still, there is hospitals that I know in Asia still use central monitoring plus like a data warehouse connect. It's not costly. They also use those two dashboard to do the network hospital collaboration. They said it's okay. Still, the outcome is there. Of course, they want more, like AI and more dashboard, like a Westchester Medical Center. They don't have that. But they can still conduct collaborative medicine and also train the bedside people and also the command center. So that's the most realistic approach that I would recommend for you to consider, because it's a less costly also, and also at the same time provides a culture change and all that. Start small, I think, is the most important, because, and when you start small, it could be specific unit, it could be CCU, right? It could be PQ, but pick and choose the unit where the staffs have more ambition to adopt, welcome the technology, welcome the new way of working, check the energy level there so that they can be your hospital's champion at the end of the day. So the management team should support those specific unit who are going through this trial, practice, and developing the workflow, and share their outcome with the other departments to motivate, because you are proving yourself that this is working. Of course, from lots of curves and hard, circumstances you have to go through. It's not easy journey, but eventually it works with the less technology. So does that kind of combines all your questions, or did I miss anything?
Apakah itu sudah menjawab seluruh pertanyaan Bapak atau Bapak ada yang mau tanyakan lebih lanjut? Oke, advanced question from the questions. Oke, pelan-pelan Pak supaya saya bisa jelasin. You've mentioned before it's a baby step, so phase 1, like a small or a simple one. Yeah. We have CAT lab, we have CC, we have ICU. And based your experience, if we are choosing the specific units, which one should we pick first? Yeah, pick first.
Yes, of course. And you can do it with just the management decision, but again, adopt. Sir, my recommendation is you have to kind of have an open discussion within your team. Hey, this is the smart hospital. I'll share my slides with you. Nothing is secret here. And check their energy level. If you are leadership of your unit, check their energy level first. There's no right or wrong answer. Every hospital is different by different. Like I said, some of the hospital, they only use command center with less technology for rapid response team only. What's wrong with that? And is that right? No, it's just that's where your staff, the clinicians wanted to adopt. There will be some of the units they don't want to adopt because I'm already burned out, overwhelmed with the existing workflow. Don't add this technology task force on top of my existing work. So I don't know. I don't have, unfortunately, the visibility of your department status. So it's more on your internal discussion. Of course, invite me when you want to have that discussion so that I can maybe facilitate, moderate.
Oh.
Yeah, so that I can help you and your team to, avoid misunderstanding. Yeah, because that's most critical. Because co-create workshop, coming back to that again, bottom up. That's the core success factor. If you don't communicate, if you don't emotionally align with them, all your investment will not work.
Okay. Is it clear, Mr. Harudin? Is it clear? Okay, enough. One question? Is there any question? Bapak Ibu? Ada lagi pertanyaan Bapak Ibu? Cukup ya? Cukup ya? Okay. I think there's enough for today. Is there anything that you want to add?
No, I think I said it a lot, and thanks for listening to my somewhat emotional presentation because I've met almost hundreds of hospital C-suites or like large group. Even I conduct co-create workshop many times, and now I'm very matured, very professional level. All the questions that you mentioned today was very insightful. I really respect. That means you are really considering of smart hospital and you have a big love for your hospital. As a result, I wanted to kind of, yes. And that's why I wanted to kind of stress the importance. That's the key takeaway. The importance again, data quality, yeah?
Data quality.
Not AI.
Not AI.
And the consensus bottom up. And you can start small. I'm sure my President Phillips may not like me, but I want to be very realistic. Lots of best practice, small scale works. Of course, takes lots of effort from the staff, especially. Capital investment is required too, but relatively all the big cases that you saw, it's very small. So do take that approach and also do the co-create workshop, which we definitely want to support. So really appreciate again. Thank you for your time.
Thank you so much.
Look forward to meeting you again in the future. Thank you.
Thank you so much. And that's all for today. The Healthcare Technology Seminar for Harapan Kita. Once again, big applause to Mr. Kevin Kim. And you may dismiss. Thank you so much.